We are recording.
Okay. Hi, everybody. My name is Mariah. This is my capstone project. The title of this project is Substance Abuse in Pregnancy and Infant Effects. I want everybody to go around and introduce themselves. Okay. Savannah.
I'm Savannah Talbot. I'm an LPN and I work at a pediatrician's office.
Okay. Mom.
My name is Christina Carpenter and I'm Mariah's mom.
Sydney.
My name is Sydney Smith and I'm currently a nursing student at WVU.
Okay. And Aunt Becky.
My name is Rebecca Nesbitt and I'm a registered nurse.
Okay. Thanks, everybody. So infant effects of intrauterine substance exposure are a big topic that has recently become more pronounced in the society of today. In the last several years, researchers, medical professionals, and teachers have become very interested in knowing the long-term effects that this has on these babies, as well as the short-term effects that it has. The state of West Virginia has become overrun with substance abuse, especially during pregnancy in the last decade. The opioid epidemic has a lot to do with that. Since it's relatively newer, we don't know all the lasting effects that it has. Many different professions see the effects of this epidemic and the consequences it has on society as a whole. The plaguing and continuously growing issue with this epidemic is the fact that pregnant women are abusing drugs throughout their entire pregnancy. This problem has led to a condition in newborns known as neonatal abstinence syndrome, or NAS. These infants have full symptoms of withdrawal from these substances, which can lead to many issues and can cause a very trying, difficult time in the beginning of life. This study is going to be important because these kids are our country's future. They're going to be the future doctors, nurses, scientists, any position that is going to be the people that are going to take care of our country whenever they're older. As adults and medical professionals, it is our obligation to serve the vulnerable population, which includes children. Learning and understanding the lasting effects of this type of exposure may be life-changing for these infants and children. Finding the best practice for treating these infants is critical in the lasting effects of this illness. Obstetric floors, such as the one that I work in rural hospitals, are being overrun with this patient population. The hospital that I work in is in rural Bridgeport, West Virginia, where these patients are becoming more and more frequent. Nurses and physicians are often questioning the type of treatment that the NAS babies are receiving. As medical professionals, we take an oath to care for the patients and do no bad for them. The pediatricians and nurses that take care of these patients try to provide the best care that we know how to give, although we don't always know the best practice because it's so new. There's always room for improvement in medicine, and practices and treatments are ever changing. The purpose of this study will be to find the most recent and effective treatments for withdrawing infants, as well as knowing the long-term effects of neonatal abstinence syndrome. Okay.
I do have a question.
Okay.
What does your hospital do now for these infants?
So there's no set, like these are the guidelines, which is what I find so troubling. There's recommendations, I guess, on different things that we know help with these kids. Like, prime example, if they're withdrawing, we know that swaddling them helps. Well, another issue with the swaddling is, okay, while swaddling may help, also swaddling causes them to get sweaty and they're getting hotter, and that causes increased irritation, and fever is a side effect of withdrawal anyways. So it kind of seems like there's no like one way that's fantastic. And also with their feedings, these babies often have excessive suck. So they just suck, so they can overeat very quickly. We don't have a set thing like we use a slow flow nipple or anything like that. It just kind of is what works for each child. And I find that like super frustrating because I want to do the best thing for all of these kids.
Okay.
Okay, that answer your question?
Yes, it does.
Okay. Alrighty. So the study, the purpose and proposal of this study. The following research proposal is to gather data on the congenital anomalies as well as the long-term effects caused by substance abuse during pregnancy. This study will allow for a better understanding of how to treat these infants as newborns, as well as through childhood to promote the best development with the least amount of side effects. So this is because these kids are born and they're born with withdrawal or other issues that are congenital. Like if you do the research on it, so many substances cause all these issues that we never even knew that they cause, even just congenital anomalies like with developing their heart or things like that. It causes all kinds of things. So the issue is so prevalent at the facility I work at in Bridgeport. We're constantly seeing mothers come in with either zero prenatal care or very limited prenatal care. These mothers' drug screens come back with sometimes more than one drug. I've seen them come back with 3 to 4 different like substances, like methamphetamines, opiates, fentanyl, even just like cocaine. They come back with all kinds of things. The babies that are born to these mothers, specifically the ones who use opiates prenatally, are prone to develop neonatal abstinence syndrome. This syndrome is characterized by tremors, increased muscle tone, excessive crying, poor feeding, slow weight gain, increased respiratory rate, fever, like I stated earlier, as well as sweating, troubles breathing, diarrhea, sneezing, and if it gets severe enough, they can have seizures. We do at my facility anyways, every 4 hours with the infant's vital signs, we record an NAS score. So we look through all of the different symptoms that they're having and check for all of these things, ask the parents, or if they've been in the nursery because they're in state custody, the nurse, whoever takes care of them, like monitors these symptoms throughout the 4 hours. So if they score a certain score, then we have to start them on a medication. And at my facility, we do morphine. So I kind of want to figure out ways to maybe prevent it from getting so severe if you can, the other things that can help calm them down or chill them out. Because often I find that, okay, well, maybe the baby's overeating, so that's making them more gassy, so they're screaming and crying. That may not necessarily be related to substance abuse, them withdrawing from that. That could just be a normal gassy baby. So if we could prevent them from getting gassy in the first place, maybe we can lower their scores before having to start them on morphine, because once they're started on morphine, then they're getting it every 4 hours for sometimes weeks. And that's really, you can think that would be terrible on a baby.
And then
especially
that
being
has to be titrated in itself.
Yeah. Yeah. And you only can titrate it if their score is below a certain number. Like you can only take it down if they are under 10. So we had a baby not too long ago. He was there for 2 months. We had him, he was like 62 days old when he left. Yeah. So that's what I'm saying. Once you start them on it, it's like, okay, now you have to withdraw them from yet another drug, which is terrible. Okay, so the purpose of this study is going to be to provide the best care for these infants and children by gaining a better, I'm sorry, my phone is trying to tell me low battery, gaining a better understanding on all of their side effects and symptoms. There hasn't been a ton of research on this project due to like I said, the opioid epidemic being a more recent crisis. The long-term effects are unknown because these children are just now reaching school age and we're seeing more developmental and behavioral issues. Like prime example, fetal alcohol syndrome. This is something that's been around for years. We know what it causes. We know what it looks like. It has a certain look to it. You can tell these children when you see them sometimes. Whereas with neonatal abstinence syndrome, while the opioid epidemic has been a thing for a little while, it's not that it hasn't been so prevalent where we're seeing it all the time. Like opioids were a big deal, but now we're seeing pregnant women doing the opioids like they are. And that's becoming worse in my opinion. So we don't know what these kids are going to have as they get older. They may have issues like withdrawing at first, but what type of problems are going to be lasting into their childhood? Things that we need to have a better understanding of so that way we can take care of them or even allow preventative measures to keep it from getting so bad. Okay, so I'm going to go ahead and talk about how I'm going to do this research. So in order to conduct this research, I will use what you call experimental research. I'll use 2 different groups. One's going to be a control group and one will be the experimental group. My group, like my sample size will be of 100 people. I'm going to use 100 couplets, so being a mom and a baby. Of the 100, I will use 50 that use substances throughout their pregnancy and then 50 that did not. This is kind of going to be on a randomized trial. I'll let them, they'll come in, they will deliver. And after they've delivered and we have their results back, whether they were on drugs or where they were not, you have to get consent from them and let them know that we'll be anonymous, but we will be recording any symptoms the baby has. This will be easy kind of for the babies that are state custody babies, as bad as that sounds, because we'll just get CPSs accepted. So that'll be fine. And normally with these babies, they stay closer by, so we'll be able to watch them a little bit easier. So I'm going to use 100 women and newborn couplets between the ages of 18 to 30 who are not already predisposed to having infants with congenital defects. So this will mean that there's no, it'll be more accurate because there's not women that already may have had a baby that had an issue. We'll use all people that don't already have that pre-existing disposition to do that. The research will be completed on a randomized basis, like I said, and we'll have to gain consent. And okay, that's going to be my sample. As far as data collection, we will gather the data by healthcare professionals, such as the nurses and the physicians that I work with. Those will be the people that initially gather the data. We'll record whether they have congenital anomalies or any symptoms they have, or if they're developing NAS, or, what if they have to start morphine. We'll collect all of that stuff and put it into a spreadsheet. Now, as far as when the babies are discharged and they go home, hopefully the babies that we choose will be following up with a pediatrician at our office, like at UHC. So it'll be a little bit easier to follow these babies, or we'll have it like with CPS that they will continue to give us information on these babies, how they're doing and any records that they're having. Okay. So all data will then be placed into a spreadsheet for easy translation into a pie chart. The pie chart will allow for the ease of comparing the percentage of infants who were born with certain congenital defects, the percentage who were diagnosed with any symptoms and conditions and what they were, and lastly, the percentage of infants with long-term effects and what those effects are. So this will allow for easy comparison of all of the things. We'll be able to look at them and say, okay, this percentage of kids that were exposed to drugs prenatally had this issue. This percentage that were exposed didn't have this issue. And then maybe some will be able to use that control group of the ones that weren't exposed to compare it to that and say, okay, what was the real percentage of that likelihood?
So what are you going to be doing different to prevent, has there been studies done that is similar to this, and what will you be doing different?
So from what I've seen, there has been different studies that they record, like, okay, this baby had this issue into childhood. Maybe some they're finding a prevalence in some kids, but there hasn't been like such a I guess like an extensive study, like over several years to see, okay, they're born, they have this, or they don't have this. Okay, now that they're age 5, they have this, they don't have this. It's not been like the same group of kids followed, which is what I hope to be able to do. Okay. Of course, you have to think that, well, maybe you'll lose some because maybe you can't track them, or yes. But I'm hoping that we'll at least be able to get some, especially initially, to see how it's affecting the babies and at the beginning of life too.
Okay.
Okay.
Yeah, I feel like it's important to follow them like throughout their, visits with their pediatrician and things like that. Because currently they just kind of get, they get the diagnosis at the hospital, and then after that, they just kind of move on instead of following it. So I think that would be really great for their care.
That's my thought, because what I hope to do is follow these kids, and then that way we have that information and data, and we can say, okay, this is what we found is something that's going to be common with these kids. Like, per se, even maybe we can take it down to like what substances their mom used. Okay, you were exposed to opiates prenatally. Okay, that means that you have a really high chance of developing this developmental disorder or this behavioral disorder. So let's start some type of therapy or something to prevent it from getting to that point before we notice it when you're 6 or 7 and it's already out of control. You see what I'm saying?
Do you plan on doing anything different with the infants?
That's also I think when I think of my project as a whole, that is my main goal, because that's where it affects me directly. I mean, I'm in the nursery all the time with these babies, and I just love them, and they have my whole heart whenever I take care of them. Like that one I had for 60 days. I mean, I could probably cry thinking about him. I just love him. But I just want to be able to take the best care of them. Like maybe there's a certain formula that we need to start them out on, maybe there is maybe they need different swaddle blankets that are a thinner material. We need to have them for those. Maybe they need to have more scheduled things, like, okay, you eat at this time, you do this at this time, maybe they need a regimen and more of a schedule. That's what I wonder.
Another question I have, I know that each individual baby, as far as like they have different intolerances, such as soy or, like a Gently's formula or something. Is that going to, will the formulas be all the same throughout this?
Like, okay, I see what you're saying. Like, are
Yeah.
they gonna have, okay. So typically, I guess that would come down to, okay, is this a colicky baby? Is this a more gassy
Mm-hmm.
baby? Does this baby have a whatever? In the hospital, at least, a typical baby, like that's not withdrawing, those babies all start out on Similac Pro Advanced. That's what we start them out on. So they would all start out on that. And typically within those first 2 days, we don't see a lot of intolerance. Do you see what I'm saying? Like
Mm-hmm.
with those, like a normal non-withdrawing baby. A lot of our withdrawing babies we have for longer than that. We automatically, if their mother has a positive UDS, we keep, which I mean, you're in drug screen, we keep them for 5 days from the get-go. So within that amount of time, we do start seeing more intolerances. So we start them on Alimentum or Similac sensitive or something like that. So, I mean, there a while ago, one of the physicians I work with was doing half Alimentum, half sensitive. And it was like, okay, I mean, it worked well, but that's the thing. Where is that coming from? What evidence based practice is that? You know? So I would just like to find, and we don't do that for every baby. So that's what I find frustrating. I'd like to be like, okay, this is the mixture formula that works best for these kids. This is the things that all of these kids need throughout their treatment.